endodontics. So, as you can see, implantology is really getting big, you know. It has surgical procedure, severe complication can occur. And you should know that you can have to prevent them, how to solve these problems. So, we really should classify. You should know that you're going to have some problems, surgical problems, whether you like it or not. Some of them are accidental, and some are complications, and some are early stages, and some are late stages. So you should be prepared for all these 4 stages. Which one should I tackle? Okay? Now, to start with, the failures, you know, occur when the professional or the patient do not obtain. We just heard 2 professors here, 2 doctors here, periodontist or prosthodontist, gives you that. It could be from you, it could be from the patient. Okay? Iatrogenic comes from the Greek word iatros. Iatros in Greek means a doctor. It means the doctor himself did the job. You know, iatrogenic. So that can be from you. You know, regardless, accident complication caused by deficient practice of the profession. This is well known in medicine, iatrogenic medicine. Now, early stages, when it starts by simple like this: infection, edema, ecchymosis, emphysema, bleeding, flat adhesiveness, or sensory. These are the things which happen in implantology as well as in oral surgery. Okay? Late, now you have a patient comes to you and he has perforation of the mucous membrane or mucoperiosteum, maxillary sinus problem, mandibular fracture, field osseointegration, we heard a lot about it today, bony defects, and implant lesion. These 2 guys before, just for the record, Mish and Wang, they really do a lot of good jobs. I'm sure you all know about carbonation. Late is the classification from Carranza. That's the godfather of periodontics. My boss would not consider him the godfather of periodontics. My boss, I graduated from the University of Michigan, and my boss, some of you probably know his name, Ramford. Ramford has 3 books in periodontics and occlusion and so on. So the 2. Because Carranza in California, Ramford in Michigan, the 2 just don't lie. Everybody thinks he's the god himself. This other guy is a false god. But this is really true. Carranza has surgical, biological, technical, ethical, aesthetic, so to speak. Now, surgical complication is hemorrhage, there's nerve problem, and then damage to the teeth. Whereas biological complication, inflammation, adhesiveness, and periimplantitis, as Dr. Basil Gabriel said, and the implant loss of failure. Well, the technical complication, Dr. Turkat, he talked about it, so we'll leave that to him, and the ethical part, we'll leave that to him. Bleeding. Now, the cause of bleeding, lesion in the sublingual, and perimandibular or facial artery. I'll explain to that, you'll be surprised. Surgery in the lower anterior area, that's really an interesting area coming very closely these days. Especially either edentulous or non-edentulous, okay, dentate patients. Right, so more prone patients fall in the following. Group 2 of medical system. Irradiated, these are the ones you really have to be careful. You don't want to touch these patients. Irradiated, or people who have intravenous phosphonate. As the previous speaker said, pick your patient. Really, you have to pick your patient. I know Dr. Basil Gabriel talked about pick your patient from the money point of view. This time, pick it from the other side, you know, so you can get successful implant. A patient who's coagulation disorder, definitely they have a problem there. And again, smokers, show up again, one more time. Now, the people who have high risk, patient with serious systemic disease, rheumatoid arthritis, osteomalacia, and osteogenesis imperfecta. Whereas the immunosuppressant people and drug addicts, anatomical patients, all these usually are high risk. Okay. Elderly, it depends on the comorbidity, you know. So, you know, he's older, he doesn't take his medication, he has a problem, all kinds of things, heart problem, valve problem, you'll have to think twice about that. Mind you, I've seen cases done in 80, 85, 90 years of patient on implants, you know. It depends on the condition of the patient. Okay. Some of these you might have to do something about the anticoagulant therapy, and we'll talk about it in a second. For example, invasive recovery performance, if you look at the INR, and if it's less than 2, you can go ahead, you know, adequate hemostasis, you follow that, I'll show you how. Or a traumatic surgery. For example, these days there's a lot of forceps which are supposed to be atraumatic forceps, periotomes, which are really good.
You know, instead of my old technique, we just dig in for the root as much as we can. You know, there are certain kind of periotomes are very nice and really will do a good job for you. All right. For the treatment, you know, you can have local hemostasis, you have sutures, of course, we know that. Hemostatic microfibrillator collagen, we know that. Oxidized cellulose, we know that. Resorbable fibrin, we know that. And something called tranexamic acid. None of you probably heard about it. Anybody heard about it? Okay, the reason is there is a big, well-known drug in the United States. And somehow, Canadians are not accepting it. My wife is a family physician. I asked her, she said, no, I never heard about it. Well, actually it is. There's only 1 or 2 hospitals in Toronto uses that. The rest of it, there's something, you'll see, there's an article in the Globe and Mail says, why aren't the Canadians using tranexamic acid? Because it's good for oral problems, especially bleeding. You know, you can use it in a mouthwash and it stops the bleeding, or you can give it as a tablet and it cuts down the bleeding. Tranexamic acid. In the States, it's called Listeria or cyclocaprone. Okay. There are some precautions to be taken. Recommended exhaustive and CBCT. Certainly. If you are worried about the case, you should take a CBCT to just make sure certain things, I'll tell you about them in a second. All right. Now, you've seen the edema, you know, swelling, more noticeable 24 hours after the surgery. And usually if you have a big flap, there's a chance. Okay, we'll do that. Or if you're using bone regeneration technique and you're digging too much deep, and always everybody knows about that surgery time. That the surgery time, there is no doubt about it. There's a good chance that the longer the surgery, the higher the problem is, you know. There you go. All right. Some of these things, we give you trismus. So, you know, if you look back here, these causes, it can lead to trismus, lack of hygiene in the wound and discomfort, and decrease with time, and can easily vanish after a few days. Okay, we're talking about edema itself. All right. Management is easy. You just have to be careful about the tissue. You have to use cold pack, and you have to non-steroidal and corticosteroid. I like to use corticosteroids. Many times I've used the dexamethasone for after surgery because sometimes it depends on the patient, depends on the money, it depends on what you want. Dexamethasone I use for swellings and really cuts down on the swelling, but also I'm really good at this, cold pack. 3 times, 4 times, every time, 10 minutes on, 10 minutes off, 10 minutes on, 10 minutes off. 3 times a day for at least 3 days. But the most important results is for the first day you have to use it. You can't come back 4 days and start doing these things. Day 1. This obviously is cheaper than this, you know, but this works wonderful too, corticosteroids. Okay? What is by hemorrhage? Now, of course, when you see hemorrhage, prolonged uncontrolled bleeding, and the amount of blood loss as a result of hemorrhage, it can be minimal, a little bit, or significant amount. And in surgery, what I mean by surgery, implants, periodontics, oral surgery, endodontics, which you all do, you know, you can see that it can occur greater or lesser degree during all surgical procedure. And depends the management, it depends on the patient, if he's normal or abnormal from the blood picture, you know. All right. Here's a picture of, some of these pictures need to just cut down the light. So, I'm going to take this down.
Yeah, I'll help you with this.
Yeah. So you can see that picture, you can see the bleeding here, you know. Whether you're going to do immediate implant placement or even surgery preparing for implant, you can end up by something like this. All right. The overwhelming majority of patients they have some kind of a normal bleeding. Okay. So some of them are not, and they have bleeding, clotting problem, for example, or those who are anticoagulant. All right. So, however, uncontrolled persistent bleeding can occur in anyone when you're doing an implant or you're doing an extraction. So it's very important for you to achieve proper hemostasis in all these patients. All right. One of the things, ecchymosis, severe bleeding, formation, massive after in the floor of the mouth as the rupture of arterial. Well, arterial trauma is really not true. It can also happen, and I'll show you a case of mine. It can happen after venous. Example, tergoid plexus of vein. Several types. You can have a petechiae, a little bit of a spots on the face, purpura, a little bit bigger, or ecchymosis. Here's my case. This is the case. This really was referred to me. This is a young lady. No, she's not young. Sorry. She actually is a very interesting lady. She is about 85 years and works for the RCMP up to now. They love her so much. She could have retired long ago, but she seems efficient. And the thing is, this lady was referred to my wife, family physician. My wife said, oh, I got nothing to do. What is it? She went to the dentist, had a simple cavity preparation, class 1 in the molar, and then suddenly she comes like this to my wife next day, and we checked, so she sent it to me, and of course, as you can see, there's the, and it's funny, if you look carefully, there is the ecchymosis, but the surgery or the restorative was done here, and that can happen in anything, doing upper molar, lower molar, you know, it depends on the channels of the lymphatics. And this is another case, but this is a very interesting case that I couldn't do anything. I told her the treatment is just really keep watching her, and we'll call the PACs all the time and just see her. In about 12 days or 14 days it went out. And usually it starts like this, and then slowly gets yellowish, and it went all the way down here. Actually, you can see it continues the case on my website. You can see it all the way down up to here, then it completely subsided. But ecchymosis can happen from anything, including implants. Okay, now the two big nasty arteries, I know, you all know your anatomy backward, forward, yeah? So there's the facial artery and lingual artery. These are really your nightmare. I do realize that the maxillary artery is another nightmare, that's definitely, but whoever thought the facial and the lingual artery? This is an area I'm talking about. This is the so-called interforamina, between two foramina, interforamina. These days we're getting reports, a lot of reports, people putting implants here and having a problem. And so we decided to see what is responsible for that. The two arteries, the lingual artery, which is branched from the external, and the external is a branch from the common carotid, so it's no slouch, you know. And the facial artery, which is a branch, see, there's the facial. It's a branch from the external and again from the common carotid. So that's another big artery. You get the submental branch and sublingual branch to the area of the interforamina itself. Okay? So if you look at it carefully, just to remind you, there is your common carotid, there is your internal carotid, there is your external carotid, and the external carotid is known by all its branches. So one of the branches you have in the beginning one, we have ascending pharyngeal, second one is superior thyroid, and the third one is the lingual, fourth one is the facial. So these are the two branches here. Now, if you could look carefully here, you'll see there is the lingual artery, and there is branches of the lingual artery. Here, for example, the dorsal lingual vein, that's the one, when you do this, that's when you see. That's your dorsal lingual vein. Then there is the deep lingual vein, that one you don't see. But both of them coming from the side of the mandible itself, and they have implication on implant placement. Okay. Other two structures sitting here quietly, for example, the hypoglossal nerve up and the lingual nerve, and we will tackle this. Now there's your lingual artery, very famous, comes out from the external carotid, famous for maxillofacial surgeons in this room. It has a kink, but it goes right on the floor of the mouth and gives up these little branches. Now these are the branches we're talking about. And you can see these, whether it's venous or arterial, these branches will come here. Now normally, in textbook, we all studied, well, these arteries, they just come in and that's it. No, that's not true. In fact, there's a lot of variations. And here's an example. This is from a paper. Shows you branches from sublingual artery. These are all branches from the sublingual artery coming here. You know, you notice instead of one branch like our textbooks, we have more than one branch sublingual artery. All right? And then, or you can get two branches, one from the sublingual and one from the facial, supplying this area. And now they are all inside here. Now remember, you're going to do implant in the anterior part. If you look at it from the inside of the mandible, there's a lot of foramina inside here. There's a lot of foramina Normally, we only know that there's one foramen. For example, we know that there's a mental spine here for attachment of the geniohyoid and genioglossus in that area here, the mental spine. What about the foramen? Well, there it is. If you take a CBCT, there's a CBCT, and you can see, suddenly I see this guy here running here. Well, that is a foramen coming. So the artery or the vein, or both of them, are penetrating this. Now, what are the signs of threatening hemorrhage in this area? Well, you'll have swelling, negation of floor of the mouth, increase in the size of the tongue, difficulty on swallowing, pulsating or profuse bleeding from the floor of the mouth. Here's the first case. Severe hematoma on anterior floor of the mouth. Okay? You try to do something, implant placement for anterior for the mandible, just the surgical part. Patient comes. The patient will never show you that immediately. You're not going to see that. He's going to come 24 hours. He's going to call you back again. Hey, there's something wrong with my floor of the mouth. And this is why. So don't be, it's not going to happen to you. Okay? It's not going to happen to you. I want to make sure you understand that. But smartness is to I'm going to tackle it before this happens. Here's another case with ecchymosis for the implant placement. And it began to happen to the chin here. Obviously, there is something wrong going with this patient. There's another one here, you know, where tremendous amount of bleeding happened. This is a different case, and you can see the floor of the mouth is being pushed, the tongue is being pushed. Well, if that keeps happening to the patient, he's home, you've done the surgery in the morning, he's home, it's about 10 o'clock at night, slowly having this or the next day. Well, that's really what happened to this patient. You had to send him back to the hospital, had the tracheotomy itself, because he couldn't breathe. He couldn't breathe. He could not breathe at all. So this is one of the things you'll have to think about. And this worst case is obviously this, you know, when you have elevated part of the submandibular floor itself here and pushing the whole tongue, stopping his breathing. Okay. Now, okay, so we can see it in different format, just like what we're looking at here. We at Western, we just, I have a graduate student doing his master's degree with me, Mr. Simrad Gill, you know, he's doing his master with me, and we are actually, there he is, and we just had a research day, and this is, that my student is studying these cases, hemorrhage secondary to foraminal implant surgery, anatomical consideration. My student is trying to identify what are the arteries, what are the nerves, and the percentage, and where it is located, so I can transfer this to the dentists who are doing implantology, and then they are really aware where am I going to see all these foramina. There are these extra foramina exist here, but you don't see them. CBCT can catch them. Okay? So what do you do for the treatment? Okay? In the posterior mandible, your enemy is the mylohyoid artery. It's a branch of the inferior alveolar artery on the side, on the medial side of the mucosa itself. It goes with the mylohyoid. Mylohyoid supplies the mylohyoid muscle here, but as the artery is coming down, it's very close to the second molar, third molar, or first molar. So you really have to be careful about that artery. The treatment, finger pressure. Why? Because that's a small artery. It's not a bad artery. Even the nerve is not a big nerve, the mylohyoid nerve. Although you don't want to cut the mylohyoid. The patient's not going to get you. And if you cut the mylohyoid, why? Because the mylohyoid is a motor nerve. It's a motor to the mylohyoid muscle anterior of the gastric. But still, you'll see some kind of a deficit there. Whereas the middle lingual of the mandible, if you have bleeding in the middle of the mandible, it's usually the artery of choice is the submental artery. Now that's the artery I talked about, submental artery. But he's just moving. He didn't reach the end. He's just moving the submental artery. Your treatment for that, it's a ligation, if you do. Now, ligation, now you gotta tell you something. You're not gonna open for the lingual artery at the time. This is a big artery, you don't wanna open the floor. But if you suspected that, I see this here, is a bleeding on the medial side of the mandible, and I see bleeding. What can I do? Actually, you could do what the oral surgeons do, is a blind suture. A blind suture is a well-known technique of oral surgery where I know you're here, but I'm going to catch you by suturing this area. And then you suture on an artery you don't see, and you'll stop. We use this a lot in the palate. We will talk about the greater palatine artery. It's the same thing. Greater palatine artery, some of you do connective tissue grafts.
it bleeds. And sometimes you don't know where is that. And number two, the palate is nasty because it's a big curvature. Try to take a suture for an artery. So what you do is you take a blind suture in the middle of the palate, right where you think there's the end, so somewhere he's here, I'm just going to get him. And that's what exactly what you do. If it's at the anterior part, that's a part which give you that big swelling, you know, it's a terminal branch. The answer is really easy, compression. Put your finger inside of the patient and make sure that there's no arteries or veins in this area. Just a compression will stop that. The reason for that, it's not a big artery. It's not a big sublingual artery. It's not a big lingual artery. It's not a big facial artery. It's a small sublingual or submandibular from the fascia. So actually we'll do that. You can do cauterization. I know, or you can use laser, but cauterization has its own problem. Periodontists hate cauterization because it gives an ugly kind of a picture, you know. But if you have to, you'll have to. And then, if the bleeding invading the inferior alveolar, you see it is coming, gushing from the inferior alveolar. In that case, you really have to put a bone graft there. The best way is to use bone wax. And I remember I was doing surgery at one time, and it's just a young girl, 12 years old or 18, can't remember, but took the molar and the blood just wouldn't stop. Wouldn't stop no matter what. So I mean I've learned the trick from long ago. It's gauze. That's the first thing. Then just get the gauze and pack it for half an hour. Wait, it will work for it. You know. After that, an hour passed. Took it out and put the bone wax and so on. But that's the kind of thing you don't like because you're not going to put the bone graft at that time. And if you put bone graft like freeze dried, it's going to come out on the spot. It's the main thing is stop the bleeding. Okay. So several materials you can use available for these things. Stop the bleeding. You know about this Surgicel. We use that a lot. We use a lot of Surgicel. It will do it very nicely. Okay. Or you can use gel foam. Everybody in his clinic has gel foam. It works very nicely. Or you can use Avatine, microfibrillar collagen. It will work very nicely. Or you can use collagen. It also will do a good job. And this is the new one, which you don't have in Canada. Tranexamic acid, 5%. As you can see, there is an article in the Globe and Mail in May 2012. It says, hospitals shun cheap drug used to stop bleeding. It's a very good drug. All Americans use it. I'm not sure why Canadians are not using it. And it comes in two ways. You can have it as ampules, and you can have it as tablets. And you take this ampule, actually, and you put it in a syringe, and you bathe the area, squish, it will stop the bleeding. It will stop the bleeding. Yes, sir?
Can you order it from the States?
Well, you can. Now, the only reason I'm going to answer you can is that hospital for sick children, they have it. But this is the only hospital. Then becomes a problem. Why is it only that hospital? It's a Pfizer. You just ask your Pfizer dealer, does he have that drug or not? Okay, but definitely it's been used widely in the United States. And of course, you know, you can irrigate, see, with the tranexamic acid, and it will stop the bleeding. Or what I said seconds ago, you have to take a blind suture. In this case, you know where's the bleeding. You can take
How do you apply it?
a blind suture.
How do you apply the tranexamic acid?
Oh, put it in the, okay, I'll go back here. You put it in this, comes in the ampule itself. It comes in the ampule, and then just squirt it on the area of bleeding. It will stop it. So, obviously, you know about this. You know, even if you have an implant, you can still use a gauze. This is pressure. My whole purpose of this is telling you really best example for stopping bleeding. I've learned that whether it's a big bleeding or small, is learn how to do the pressure and be patient. Now, if you have an intermediate hemorrhage, you know, you have to identify the site of bleeding. Is it coming from the bone or the soft tissue? It's from the bone. You can use gel foam or bone wax a lot. We use that a lot. Or it's from the soft tissue. We said ligation, cauterization will do a good job. Absolutely. If it's a secondary hemorrhage for a normal patient, emphasis here is the word normal patient,
It will occur after a few days of surgery. You identify the source of bleeding, just like what you did before, and you can use a surgical stent. Okay. Yeah. Now, if a patient has a bleeding disorder, now that's a little bit of a problem, you know. Its usual protocol, treatment of this group of patients consists of preoperative blood investigation. That's very important. That definitely will get you, oncology will get you. You knew that he has a problem. Why didn't you? I had a student of mine who really wanted cheap extraction, but he didn't tell me for his wife. And he said, you know, like I was doing a PhD, and he said, oh, gee, I went to the dentist for wisdom teeth, and they were really expensive. You know, can you help me in this? Okay, so I took history and so on and so on and so on. Actually, it was one molar, third molar. And after I started the surgery, I felt, oh, he said, I forgot to tell you, she's hemophilic. What? Are you serious? Yeah. Well, yeah, what? I was really shocked. I mean, obviously, I expected the worst to happen to this, you know. So, I decided, thank God, my clinic is in the hospital. That's number one. Number two, I really told him he's not going to leave me here until I pack this sucker for, you know, 18 hours if I want. You know, I'm not leaving from here, and I can give you injections of different kinds. And I phoned the hospital, and they came with all kinds of stuff, and they stopped the bleeding with me. You know, I did suturing, sutured over the gauze itself. I did all kinds of things. So these kind of patients, you really have to have a history. You know, some patients just don't tell you. They think, oh, yeah, you know, you don't need to know. You don't need to know what other drugs are taking. Subsequently, after, you know, after appropriate local measures are used to decrease the chance of post-operative bleeding. This is something I use. I'm not sure whether you know this or not. This is an American viscostat. Does anybody uses that? Oh, great! There you go. Very good. There you go. But sometimes I can't get it. So what do? I go to my pharmacist. There are pharmacists in this world where very good pharmacists are called. These are, pardon the expression, these are foreign dentists. Egyptians, Indians. Why? Nothing against the Canadian. I'm a Canadian, 100%. But they learn in the school how to do compound pharmacy. You know, if you get a pharmacist from Poland, he knows how to do, because they teach them in the school how to put compound A, B, C, D, and will do it. A lot of pharmacists here, they really don't know how to compound something. So I have a pharmacist who does this 20% ferric sulfate. So he gives me about 10 of these things. I have them ready in the office in case of any bleed. The thing about it, should be prepared to see, when you put this, it'll look ugly, very darkish areas. Don't worry about it. Once it stops the bleeding, that's the main thing, you know. Once the bleeding stops, later on it will fall off, you know. But ferric sulfate is the operative word. As I said, in the States, they have this thing here, you know, viscostat. I didn't see it in Canada, so I
You can order that. These are very
You can order it?
Yes.
Oh, great. Yeah. Ours, the guy asked, he couldn't, so I had to do this. I'm glad you told me. Ultradent, oh, not Henry Schein, eh? Is it? Yeah, well, that's great. Yeah. All right, so we move from this in an area which all deal with it, which is the maxillary sinus. As you can see, looks like a pyramid shape, like the Egyptian pyramid. So you remember that the part of the pyramid, the highest part is here. This floor of the sinus is toward the nose, and there's a floor toward the maxilla itself. And these are some examples of the sinus. And as you can see, the opening of the sinus is very high up here. The opening in the second meatus. And that's the ostium, so-called ostium. And then here it is, opens here into the middle meatus itself. All right, and so the sinus is here, and we're going to deal with this in many things. You know, there's an opening, that's right. And the sinus, when you look at it, you can see you work here. So you're really, this part is not yours. This is the olfactory area itself. And the epithelium is totally different. Down here is like your lungs, respiratory. Up here is totally different olfactory area. Just for fun, this olfactory epithelium in Europe, recently studies have been done, taking this and put it in people who had spinal paralysis. And this one was able to act as a stem cell and bring the nerves together for the first time. For the first time. You know, this is a big thing in the world, trying to get the people who have quadriplegic. But for whatever reason, this thing here has an ability. By the same token, I'm telling you something I told my students. I myself attended a lecture on cell biology. I was really stunned. Did you know that every hour you lose 100,000 cells? 100,000 cells you lose every hour. Like by the time this lecture finishes here, you're gone. Yeah, I was really. This is a program. The cell which you lose is called apoptotic cell death. Apoptotic is a programmed cell death. It's a programmed cell death happens for all of us. That every hour 100,000 cells disappears completely. So back to the maxillary sinus. Normally, those of you who open the sinus will come on the side, make an opening, and come if you want to increase the thickness of bone. You'll add some bone, okay, and then leave it to heal, and then implant. You can put your implant. There's a procedure like that. As long as you don't perforate the sinus. As long as you don't perforate the sinus. Now what happens to the maxillary sinus? By the way, the maxillary sinus is also called Schneiderian membrane. If you talk to an ear, nose, throat, normally they talk about the Schneiderian membrane. They don't talk about maxillary sinus. Schneiderian membrane, the same name for the maxillary sinus lining. So the membrane is a periosteum, like any other periosteum. So it has the ability to produce osteoblasts and produce more bone. That's why you have to be very nice to that membrane. You know, if you want that perforation you did and the bone you put, you want it to become bone, you gotta leave that membrane there. It will produce osteoblasts and induct the bone to be formed. And as you can see, you have a thin layer of pseudostriate fasciolae like your lungs, and an important barrier protection defense of the sinus, certainly, you know. Here's an example. Membrane perforation occurs in 10 to 60% of implantologists. Anybody? The chances are very high you're going to have a perforation of the sinus if you're not very careful when you lift that sinus. You know, it's always you hear, oh, I do lift, sinus lift, sinus lift. Well, you don't want to perforate the membrane, but these are the statistics. Okay, here's the perforation, and sometimes you really have no hand in it. Anatomical variation. You know? Septum. As you probably know, septum has many rooms. The sinus has many rooms. Or thick, you know. Maxillary sinus walls are very thick. Or the walls angulated, not that what you expect in the textbook. So you try to go with your instrument in different ways and you perforate that sinus. I'll tell you what you could do. At first, there are some nasty cases. After completion of implant preparation, the bed shows carefully probed to identify any possible perforation. If an oroantral fistula or oronasal fistula detected, radiograph has to be taken immediately. And if the perforation is minor, some people put short implant, believe it or not, and the patient is completely informed. That's very important, and antibiotic is covered. You will see later on, not only antibiotic is covered, you also has to give decongestants. You definitely have to give decongestants. Here's the lateral wall of the sinus, and you can see an intraosseous artery has been hemorrhaging. You know, you very carefully, you can take a mosquito hemostat, and you can cauterize that if you want. Okay. If you have a small tear, less than 5 to 8 millimeters, you can fold the sinus against itself. But if it's a large one, they really can't fix themselves. You'll have to do some kind of a collagen or fibrin adhesives in it to block that. And you hope that it will close. Not every time it will close. Why would you lose the implant for graft into the maxillary sinus? Change the intranasal. If you happen, this is going to cause that. You can cause an autoimmune reaction, or you can have resorption, correct distribution of occlusal first. I'll show you. First, I'll start with this. How do you look after it? You gotta retrieve it surgically if the implant goes in. Intraoral approach. Or endoscopy approach. You don't do that. But you can let an ear, nose, throat do that. They go endoscopy in the nose and they can take it from there. But you can do this one. Or a prevention, bone reconstruction procedure of maxilla should be performed. Now, here's my case. I was working with someone, not telling any names, and he was putting an implant, and I was in the other room doing surgery, maxillofacial surgery, and here's the case before, and here's the implant in the sinus. He was drilling, and just there, he jumped in the sinus, so he asked me help. So what I used the cold will look technique, where you make a window, I open, push as much as I can. And the problem with this is really rotten, that when you have a sinus and you have something, it doesn't matter, it's a tooth or it's an implant. You tell the patient, sit, I'm taking an x-ray, you take, now tilt, I'm gonna take it, implant moves, backward, forward, so you can't locate it. The same happens in the teeth. I had a case, just first time, I put an elevator, third molar up in the maxilla, and I said to the patient, I don't like this, you know, I might have a suffer. Just I touched the elevator, it's just jumped on the side. My problem wasn't, I could get that, the problem was the x-ray. I put the guy, tilt him, take the x-ray, the tooth goes this way. Now I open it, goes that way. So what am I going to do? Anyhow, so I made a big opening, go to a look operation, and went. And this is the kind of thing. Okay, take the side. That's what the so-called cold will look operation. Okay, if you happen, as you probably know, oroanteral fistulas are not easy to fix. You know, people always say, oh yeah, you can have an oroanteral fistula. And the reason is the anatomy. I started by the anatomy telling you in the beginning, the opening of the maxillary sinus in the middle meat, a second up. Okay, so the drainage is always down. So whenever there's an infection, and always get an infection, it will always drain from the oroanteral fistula all the time, no matter what. You know, so the trick is to cover this oroanteral fistula. You can have a flap, pull up a flap, pedicle flap like this one here, or really if you want to be aggressive like this, take a flap and put it back here. Any of these will cover it. Other than that, you can't. You know, you really can't. Some people do an aggressive thing. They don't want to go back to the sinus, but what they do is they go into the nose. I used to do this. They go in the nose and drill straight forward in the nose. If I drill straight forward in the nose, I'm at the lowest cavity of the sinus, the lower part. Therefore, the drainage is from that part. But he has to walk with a gauze in his nose all the time. And the reason for the gauze is to keep it open. It's always have Vaseline in it. It keeps it's like drainage. And then after a week, take it out, and it will close by itself. By that time, the oroanteral fistula healed. That's the whole idea. Okay, but it's very important to know that oroanteral fistulas are not easy as they suggest. The blood supply of the maxilla, that's the nice part of this whole talk. The blood supply of the maxilla is derived from infraorbital artery, greater palatine, and posterior superior. These arteries, you know, outside the sinus. That's the good part about it. These arteries are all outside the sinus. Infraorbital is right here, okay? Greater palatine is back, you'll see it in a second, and posterior superior at the back of the maxilla, okay? Here's the greater palatine artery. There you go, right here. It's been coming down here. There he is, here. And there it is. And then you have the posterior superior alveolar here. And then the infraorbital will be right here. Okay, there's the big nightmare maxillary artery, which we moved out from this area, interforaminal. Now it's up into the area where you're doing some work, whether it's surgery, implantology, or root canal treatment. And bleeding during sinus augmentation is rare because the main artery is not within the surgical area. So if you don't want some precaution you should do, preoperative, look at the sinus, you know. If you did not look, now I'm really stuck with it. Post-surgery, nasal decongestant, topical steroids, and after that, perioperative problems, you can get Caflex. Every 6 hours for 5 days, we do the job. You need this decongestant. When you read some books, don't give the decongestant. The reason for decongestant is opens the sinus, so drainage fast. If you don't do that, You know, if you don't do that, the contents of the sinus stays there. That's another thing, problem. Nerve lesions in both intraoperative and postoperative. These complications have low incidence. That's the good news. Very low incidence. Okay, although it's 0 and 44, but they consider them consider them low incidence. All right, so we go to this friend of ours, inferior alveolar artery, and we can see him, and I'll show you some of the things. You know, the artery, just remember, it's a major sensory, right? So we know that. It's not a motor artery, so therefore, the patient will complain about sensation, you know, numbness. Goes through the canal, comes out the foramen, supplies the premolar, supplies the gingiva, and runs nicely here. Okay. Just for your information, that we've studied that at Western. We can tell you that there are many branches for inferior alveolar. It can be 1 unit, type 2, 2 units, more than 3 or more than 4 branches from that. It comes in any shape it wants. That it's not like what the textbook talks about. That has an implication when you put your implants. You can see divides into 2 terminal branches. Incisive nerve continues in the mandibular canal, supplies the first premolar, 9, gingiva, mental nerve exits through the mental foramen and supplies the lower teeth. And there's our mental nerve coming out from here very nicely. Right? And there it is, right? Supplying the teeth. So the mental nerve has a big importance in implantology. All right? First, I want to remind you by the mylohyoid nerve. Right with him is the mylohyoid artery I talked about. Right with him, exactly. But the difference between the two, this is very close to the mandible here, because he has to come down. So this is what I told you, the artery, you compress your finger and you stop that bleeding. Okay. Mental nerve, we all studied it this way. That's not true. Here's a good example. For example, if you look at this case, you need an implant, and you can see loss of the vertical alveolar ridge height, here, or loss of vestibular. Not only that, you can see that the mental foramen and the inferior alveolar nerve are very up, right up here. Okay? Very common, especially in an older person, lost all his teeth, mental nerve was very high, up here. When you have an instrument, when you're working, and you come close to the nerve, the patient, even under anesthesia, is going to tell you something hurts. Even his anesthesia, under anesthesia. Studies have shown that happens. Implant installation should be postponed and shorter implant should be placed. You know, we heard in the morning, yeah, long crown root length and so on, that's true. But when it comes to the inferior alveolar nerve, you really have to be careful about what you're going to choose for that patient. And a several implants, an inferior alveolar nerve patient was supposed to operate paresthesia. You know, decided, look at this, it's in the nerve, right in the nerve. So, like, where was this guy? What's the causes for these post-surgical intra-alveolar edema or hematoma? Temporary pressure increase, especially inside the mandibular canal. In fact, there's a professor at Toronto, and she does studies on the relation between the implant and the nerve, even without touching the nerve. The torquing of the implant itself, she doesn't know. She gave us a lecture, and she has studies done on implantology in Toronto, and she was showing cases where the implant did not touch the nerve, but the patient is complaining of sensation. Do you know Gabaldine, her name is? Gabaldine, she's a professor of prosthodontics. She gave us a lecture showing that even if the implant here and the inferior alveolar nerve here, by torquing, just torquing, that pressure from that implant on the nerve induces sort of paresthesia. Or direct compression, stretch cut, overheating, and I thought Dr. Basil Gilrael talked about the overheating. You know, it really has an effect. I don't know nobody uses overheating. I mean, that's the whole idea of implantology. Very, very, very slow drill. But if you're in a rush, you do something like that, you can expect some problems to happen. Poor flap design, traumatic flap reflection,
accidental intraneural injection, or the most famous one, traction of the mental nerve in the elevated flap. Okay, or penetration of osteology and perforation, compression of implant body in the canal. That's the one from the University of Toronto. Traction mental nerve is really a very strange nerve, very strange nerve. I did a colleague of mine who's an endodontist. He wanted to do epicectomy or episectomy, as the British say. Everybody has his own pronunciation. Americans say epicectomy and British episectomy. So I did, and it wasn't the primo. I did everything under the sun perfect. So cut the roots, cut everything, put the flap back. She comes back, she says, oh, I got numbness here. I did not even touch the mental nerve, just reflection from that part itself. So I've done, I'll show you some of the mapping and so on and so on. It took about a year to come back to normal sensation. So don't ask me why, since I did not deal with the mental nerve. Nerve injury might cause one of the following: paresthesia, which is numb; hyposthesia, reduced feeling.
Dr. Galil, if I may ask a question.
Sure.
It's been mentioned by some other authors that if you sever the mental nerve, but
Right.
the mandibular nerve is still intact, you will get budding from the mandibular canal and new sensation again. Is that
No, if you talk to neurosurgeons, then you forget.
no?
Absolutely not. Neurosurgeons, no. In fact, the neurosurgeons, they hate it when we have a case where the lingual nerve is being cut or the inferior alveolar being cut, because they really have to sew inside the canal itself, and it's painful. It doesn't happen. In fact, something called Wallerian degeneration happens. The nerve goes back and leaves a bigger space.
What about when we're doing soft tissue grafting, we may sever the nerve, the mental nerve?
Right.
Even then, you won't get any budding or reanaesthesis?
Absolutely not. I mean, this lady, my case, I was really shocked because I did not even sever, I did not touch the mental nerve, yet she comes with this numbness here. It is obviously the flap. I mean, if somebody will attack me, I'll say, hey, it's your flap. It was, it was close to it and something happened. So, with all due respect, no. It
Would it
wasn't.
be from local anesthesia as well?
When I gave the anesthesia to it, well, because I agree with you, I didn't give local, I don't like the mental nerve injection because I want profound anesthesia, so I went for the inferior alveolar itself. But you might be right, when I put some epinephrine around the area, maybe that's what happened. Yeah, it could be.
Neurotoxicity.
To stop the bleeding, so that she got it from that part. Or you'll see, now wait, you'll see the nerve now. He'll meet the nerve in a second. So you have this painful sensation, that's bad. These one are not bad. The patient say, oh, I feel numbness. That's what the lady told me. I have numbness here, okay? And this one, I hyperesthesia, really, reduced feeling. And this is a painful one. This is not nice. And then complete anesthesia. I just don't feel it at all, okay? And this is the same doctor, Tarno. Dr. Shuketi talked about it. Tarno is one of my professors. He's at Columbia University, but he's a periodontist and very big on implant, and he used to come and visit us in Michigan, so I know a lot about his techniques. He's a very good guy, really good guy. Sensory testing, sharp needle testing, I'll show you that. You can use the sharp needle to do that. And Royal College says you've got to document it. You've got to say, on this day, at this time, I did this, and I did testing in this area itself, and the patient felt it or didn't feel it at all. This is what I did for that lady. I kept documenting, and then at the last, she said, it's painful. I got the job done. I'm glad it hurts. From my point. Yeah. So sharp needle, short test between you go between 2 points, mapping the area, and blunt cotton swab. That's another thing. You could use that. I like this one because sometimes it doesn't hurt. This one hurts, so they really will know. And then I'm not a sadistic person. I'll make that very clear. Pulse testing for the teeth and temperature test. You could do that too. One of those. I don't know. You're too young, but I'm not sure any of you uses ethyl chloride in the clinic. No. Okay. For a long time, and you still can buy it. For a long time, you can take a cotton pellet and you put ethyl chloride. They sell it, and it becomes like ice. and then you can put it. Nowadays you use the pulp test. The trouble with pulp test, it only tests the teeth. But this ice, you test the soft tissue at the same time. Okay? Ethyl chloride. I think they stopped it. The reason for ethyl chloride stopping is that you can anesthetize somebody with it. If you put it in your handkerchief and put it in, it's gone. It's gone. It's gone. So that's why they probably don't want to sell it to you. I used to use it during my days at the residency. I used to use it on. That was legitimate in Britain. Used to use it on the children. You put it in a mask, anesthesia mask. There's nothing except oxygen. You put ethyl chloride, put it on the child. Within about 3 seconds, he's gone. Take the tooth out immediately. But they stopped that. They stopped that completely. Even Britain has something even used to be worse. Which how many of you have nitrous machine in your office? Okay, there you go. You notice your nitrous never goes more than 70. Well, in Britain, it goes to 100%. 100%. So there was death. A lot of death used to happen because you could jack it up. 100 used to be great, within seconds. So now Britain is back to the way we are here. So here is the needle. Oops. Here's the needle. You can do the test, or you can do what I did. Exactly. I divided the area, and then I mapped it, and I wrote in the chart, patient chart. These are the areas. This is what I did from the midline, and these are numbers, and high, low, and so on. But that's what you're supposed to do, and you're supposed to do to tell the Royal College about it. All right. What if you don't want to get any nerve injuries during placement of implant? So look at that. Back again to Dr. Bassett Gabriel. Include nerve injury as an item in the informed consent. A patient has to know there is something, Not that I'm going to do it for you, but it might happen. Look at your radiograph, apply the correct magnification, and I'll show you a slide by that. I'm very big on this one. Is the buccolingual position, crestal peak of bone influencing the measurement of the available bone? You have to look carefully. And position of the nerve itself, How do I know the position of the nerve? I'll tell you a little bit. You either have a CBCT or you know your anatomy. There's no other way, okay? And then use coronal tooth size tomograph, SVCT. Allow 1 or 2 millimeter safety zone, very important, very important. Take care of the counter sinking, not to lose support of the cranial bone, and keep radiograph and calculation the patient chart as powerful evidence of meticulous patient care. That's very important. Rheumatology is big on X-rays. Too much proximity between the implant. Dr. Shirket talked about it, and Dr. Gabriel talked about it. Treatment with corticosteroids. That's Dr. Mish is very big on that to control inflammatory action that provokes nervous compression. Topical application of dexamethasone, or oral administration, high doses, 1 week of injury. And I think we have a picture from Dr. Mish. He does that. In fact, he says if the patient during the implant has pain, you can use dexamethasone right on the spot, right here on the spot to cut down on the pain, because he's not going to let you continue, But he says using that cuts it down, on the inferior nerve. Obviously, microsurgery to establish, which we talked about seconds ago. Check at different moments to determine the evolution of the lesion, and resort to microsurgery, which is not you. It's either or maxillofacial surgeon or a neurosurgeon, definitely. Especially, and it stayed for a long time. Mental nerve. Innocent nerve. Well, if you look at him, you should remember, if you want to know where is he, 25 from the crest, 15 from below, and 25 from the midline. You want to know where is your mental nerve, or any patient's mental nerve you can't identify, for whatever reason, 25 from the top, 15 from the bottom, 25 from the midline. That gives you where the mental nerve. This is another one. This is really, I remember that from another anesthetist who's called the Monheim. Those old guys here who remember his book, before Stanley Malamunt. Stanley Malamunt is the big guru of anesthesia, right? How many of you know Stanley Malamunt? There you go. Yeah, Stanley Malamunt is a big shot. He's in Colorado, and you can take his course. It's really interesting. But before him was Manheim. But this is really well-known technique. You take the supraorbital notch, you take the pupil of the eye, and you take the infraorbital, you make a line, it will hit the mental nerve. Straightforward. If you make that line, it'll hit the mental nerve. You know where is the if you want to know where is the. This will help you in even giving anesthesia. You know, I don't know where is the mental nerve, then this is it. Yeah. 25 for from the corner of the mouth, okay, and 25 from the symphysis, and 15 from below. Now, this is where the nice is about science. Mental nerve, really, this is what you're accustomed, between 4 and 5. That's not true. A lot of papers are saying it could be anterior, it could be posterior. So look at your x-ray carefully, say where is he located. It could be, see, this guy here, the studies here, which shows that the mental foramen can be right between, almost close to the first molar itself. These are all the studies that have been done. Right? Here's what a mental nerve can look. And you can see there's several kind of branching. And not only that, more than one mental foramen is inside. So there's the outside is what you saw, but actually more than one compartment is inside. And then it can have, see, 3 mental nerves coming out. Okay? We'll continue. The mental nerve becomes the incisive. I'm not going to talk about it, but some of you maybe, I don't know, some of you probably do block grafting. Some general dentists do that, where you have problems like Dr. Gabriel talked about. You might have to do a bone graft. You've had implant which failed. You took the implant out. The patient wants an implant. I don't have a space. You do blood grafting. Blood grafting is not bad. It's really easy. It doesn't have too much bleeding and so on. People who do that, general dentists do that. They do blood grafting. Take it here. We had done a study at Western to see why is it that you do blood grafting, patient comes and complains of numbness here. So one of my students, Danielle Ivy, she did her master's with me, and she came up with certain numbers. If you go 8 millimeters below the root, you are absolutely safe. If you start coming close to the root, you are in trouble because of the plexus of nerves here. But I'm really going to move on to the other parts. Just remember also when you drill for your implant close to the mental, the bone is very thin, there's a very good chance you can come out from the other side. You might not see it. You might not see it unless you perforate the skin and mucosa, but it's already done that part. So you have to be careful in the area of mental nerve here when you do your drilling. Another thing about the mental nerve, flat, mental nerve is very close to the surface, very close. As the flatter it is, the higher the mental nerve is, so you should remember in an older patient. This is the mental nerve in its glorious format. There it is. There's the inferior alveolar nerve, and there's the mental nerve, inferior alveolar, and look, tube, and another one, look, it comes totally different. The mental nerve, I want to tell you, the big problem is the loop. People don't know that, or they know. There is a loop for the mental nerve. It's not straightforward. It has a loop. And if you don't know about the loop, you are in trouble. Dr. Tarno, this is from his paper, he published, he said, well, not everybody can afford CBCT. What can I do if I am up somewhere and I don't know is my mental nerve has a loop or not? Okay, so he uses this cow horn, and he says if your cow horn straightforward goes into the canal and stops, then you have no loop. If your cow horn digs into the canal, disappears, then you definitely have a loop. What's the implication for that? Is that if the loop is here, and you put your implant thinking that this is your mental nerve, you are right into the mental nerve. You get the point? If the loop is here, there's the mental nerve coming all the way. And there's the one we saw in the x-ray, or this is what we think on our textbook, but actually we are attacking the loop itself. So we really have to look at the loop itself. Here's a good example of a CBCT, and you can see the loop goes all the way and comes back. So anything here, really you'll have to be very careful if you're going to do your implant. Just, look at your x-ray. This is a very lucky shot, obviously, because it's a panoramic x-ray. It's a really lucky shot. you can see the loop itself. Not every time we get it right. We all know that. When we take panoramic X-ray, we all know get it just right. So we can see the nerve, we can see the loop, and we can see the exit of the mental nerve. This is a paper from Tarno again, and it's really a nice paper. I like it because periapical have a distortion. 14% of your periapical, you remember, I think it's Dr. Shukani or Dr. Gabriel said, you better watch for the distortion. You know, which one of you guys, the distortion for the radiology, radiograph. And there it is. This is periapical 14% distortion. Panoramic 23%, CT scan 1.8. So, you know, if you're gonna get $6,000–7,000 for an implant, it's not bad to invest about $300. I don't know how much it is here, but in our dental school for $100 we can do a CT scan for you. I don't know how much outside. How much is it here in Toronto? In the school we do it for $100. We'll see a CT scan. How much is here in Toronto? 500?
150. It's 200 to 450.
450, yeah. See? Yeah, 200 to 450. Wow. Yeah. Was that 500? Really? Yeah.
That's
see?
multiple sections, multiple quadrants.
Well, we give them multiple too. If the people come to us, we give them multiple images. You know? 225. So as I said, it might be worth it, you know? And you can add it. Okay, here's my another favorite one. He's a very innocent nerve. I call him an innocent nerve. Damage to the lingual nerve leads to loss of sensation. You know that. I don't have to tell you. Anterior 2/3 is supplied by the lingual as sensory. The posterior third is supplied by the glossopharyngeal as sensory. The whole tongue is supplied by the hypoglossal nerve, which is motor. Okay? Lucky for you, you're not going to cut the motor nerve. Lucky for you. But you're going to cut the lingual nerve, definitely when you're doing third molar or impact or implants. So this can be prevented by avoiding any of the release incision. We periodontists, we learned over school, watch for the lingual release. Don't try to be gutsy, go the lingual release. Reflect lingually as much as you can, but don't cut. Don't make a vertical incision here. Must always be crestal. Okay? Flaps on the lingual side must be elevated carefully. Okay, see? Flat, no incision. Okay, that's very important. I'm going to show you first the lingual nerve, so we can remind you by your anatomy. There it is. This is the trigeminal nerve. It has 3 branches: ophthalmic, maxillary, and mandibular. There's the mandibular. One of the branches is the lingual. Now notice how it comes down. It comes down carefully and then swings to the midline and swings close to the 3rd molar. Kisses the 3rd molar, 2nd molar, says goodbye to the 1st molar, and comes back to the tongue. And this is where the trouble is. Okay? Here's a section. You're looking at the lingual nerve. So there's your lingual nerve right here. So there's your mandible here. And there's the lingual nerve at this time. The lingual nerve is coming very close and then swing to this part. Not only the lingual nerve, see there's the lingual nerve, there's some other stuff going on between this. There's stuff like that. Submandibular gland is there. Studies have shown some people ruin the submandibular gland with the implant or ruin the lingual nerve. When you cut the lingual nerve, you don't secrete. Patient says, I don't secrete. Why? Because the lingual nerve also carries the parasympathetic fiber to that submandibular, sublingual gland. So therefore they won't secrete. Beside the numbness of the tongue itself. There's your salivary gland here. There's where the lingual is. See? The pathway. Very nice. Comes here and then swings. So this is the area you have to just be gentle, especially in this area itself. Now, having said that, this is the textbook. Well, let's see what Hossein Bouhina said. Hossein Bouhina is a maxillofacial surgeon in the States, did his master's degree on the lingual nerve. So he's going to tell us what is the chances of the lingual nerve. Well, there is a study. 0.15 cases on the crest. See, thank God it's 0.15. Thank God. Okay? 22% is below the mylohyoid, which is great. Okay? 14% above the mylohyoid, very here. Okay? So you can see that average position is 3 millimeter inferior and 2.6 meter, the mylohyoid. This is obviously the one, thank God, as I said, we don't encounter this. However, without mentioning name, I remember one of our students in Western graduated. He opened the practice in Waterloo. 1 week after he opened the practice, he cut the lingual nerve. 1 week. And he asked me, what can you do? His lawyer asked me. So we provided him by this thing, saying, look, you know, not every case is be like this. If your case is like this, then it's not the fault of the dentist, you know? It's, you know, it's, we told you from the beginning there's a chance of so on and so on, but we can't avoid this kind of a thing here. So there's what the lingual nerve, so you have to be careful, you know, just like at the greater palatine. You know the greater palatine, it's about 15 millimeter from the central line here. There it is, greater palatine. That's the nerve and the artery. I'm just showing you the nerve first, because it's branched from the maxillary nerve. The artery will be a branch from the maxillary artery. This is when you inject your palate here, you inject in the soft area. You know why? Because you have a lot of fat and salivary, minor salivary gland, so injection is not hurtful as much as it's here. But your enemy is this guy here, the greater palatine artery, waiting for you. There is a greater palatine artery. So if you're doing any connective, especially for implantologists, when they want to correct some, you heard Dr. Bassel talks about correcting, you might have to take connective tissue graft. If you have a defect and you have bone loss, and you debrided the area, you clean the area, and there's a little bit of defect there, you can put bone graft, I agree with you. You can put membrane, I agree with you, but some people also will use connective tissue graft, you know, taking advantage of the actual mesenchymal tissue. But there is the greater palatine artery here. This is from a work done by Dr. Hafez. She's an MD. She came to do a master's with us. There's the greater palatine artery and nerve thing. Hafez's master was very interesting. Hafez, she did with me and two general anesthetists, Dr. Gnapathy and Rakesh. But the point is, I want to make sure before they kick me out. The point is, we came up with a technique to eliminate the needle. So Dr. Gnapathy, the head of anesthesia, is very good at ultrasound. So we can ultrasound this nerve for you, and we can tell you where is the greater palatine foramen, and give you injection. Without blindly, we can give you injection. You might think, who uses that? Of course we use that. I use that a lot if I want anesthetize the whole maxilla. If I'm going to do 2-3 implants or 2-3 extraction, and I don't want to give too much injection, I'll give injection through the greater palatine. This is a legitimate injection. And I'll go up here and deposit solution. And I know I'm not going to ask a question, but I could ask my students here. You know, if I've done a good job, what do you think the patient tells me? If I did a good job here and I really get the maxillary nerve here and now, so which area, how do I know that I did a good job? Anybody wants to answer that?
Is their eye frozen?
That's right. The eye is frozen, the nose is frozen, and the lip. Once they tell me my nose is frozen or my eye can't move it, I know that the extension of the maxillary, which comes out the infraorbital, has been anesthetized. Then I can take from central all the way to the last molar if I want to. Okay. And here's, you can see here, and of course this slide is not for the nerve, it's for the artery. And that's the nightmare for people who do implants. In this area of the artery itself, you can easily damage that because you expect the artery to be away right here, but he can be easily here, close to this part, and that's where the implant is being done. So you just have to be prepared, that's all what it is. Here is sometimes a connective tissue graft and it didn't work, and the artery took a long time to heal because of the bleeding of the artery. This is the area of that connective tissue graft. It took a long time, 34 days. Okay. Now, try to come to swallowed item. Might not be an important, but definitely this is from a paper, British paper. There you go. This thing here was swallowed, and here's screw, and here's another screw. So that I'll tell you what's the solution for these. But these are true cases. So that true cases for the implants, screwdriver, and of course you've seen partial denture being swallowed. Okay. So, and when you swallow, as you probably know, there's the thyroid cartilage, there's the cricoid cartilage, there's the
trachea, it will go down to the right side, 90% of why? Because the right side is straight, the left side is curved. So you just go there. But before it goes down, it really stop here, and it will stop at the vocal cord. That is the nightmare of the vocal cords. Here's the same from the implant. There's the screw for the implant. It's right here. Okay? Back of an implant screw drive, accidental aspiration. Okay, and here's two more, or X-ray, in showing. So it does happen, it is not. So the treatment for that, I'll tell you. Vital emergence of the instrument has entered the airways. Recommend to tie tiny and slippery instrument with silk. That is the best way. Put a big, long dental floss in it, and you're safe. No matter what happens, if it slips, you can always pull it down. You know, it went to the tongue, but they really recommend that, you know, because the alternative is gastroscopy or colonoscopy for this patient. And don't laugh, because actually this is a case from my wife. She's a family physician. But this is a case, one of the patients came to her, she said, I've been to this dentist and he told me that I swallowed the crown and I just don't know, what do you think? He told me that 2 days. Well, how long, she said. Yeah, I said, it's about a week. Nothing is happening. And as you probably know, all due respect to all of you, you have to sit on the toilet with the sieve, right? Well, nothing is happening. Nothing is happening. And you can see here, ingested the gold coin, is unable to pass after 14 days. And enclosed our 3 radiograph. You can see it was up here. There's the pelvis up here. And then it went down close to the ureter. And it's going down now into the area of the cecum or the lower pelvis. So she said, I'm going to send you to McLister, who's a general surgeon, who's a good friend of hers. And McLister, being a surgeon, like as I said, the guy who carries the hammer and everything looks like a nail to him. You know, he said, yeah, let's do surgery. Yeah, he said, we're going to open abdominal surgery. We're going to go there, and we go to the area of the sigmoid. He thought it was in the sigmoid area itself. We're going to go open and get it out. That scared the hell out of the patient. He had diarrhea at home. We're coming for a golden crown, now we're going to have a sigmoidoscopy. Really. So, but this is an actual case. This is an actual case. I mean, the surgeon was serious, but they, you know, they said everything for them. So here's a couple of things you should know. This is obviously where the trouble will be. Now, I know, when I teach even anatomy to our students, I tell them, I know, asking God, that never this happens to you, but you really should know your stuff, you know. Ignorance is not an excuse. You should know that if you feel yourself, your thyroid, as you sit here, feel the thyroid. You can feel it. There's no doubt. It's your Adam's apple, so you can't feel it. Below your Adam's apple, there is the cricothyroid membrane, between the cricoid bone and the thyroid. The difference between those two bones, this is a signet ring. It's a ring. Actually, it's the only ring, beside your wedding ring, it's the only ring in your trachea. Everything else is a C-shape, everything else. This one is a ring, so it's a tough ring. Between the ring and the thyroid, this is the cricothyroid membrane. That's where you can save your guy. Don't ever think of tracheotomy, forget it. Because the thyroid, as the British people define it, is a bloody gland. Bloody gland because it has tremendous blood supply. It has a supply from the superior thyroid artery, from the inferior thyroid artery. Superior thyroid artery is external carotid, big fella. Inferior thyroid artery, subclavian artery. That's another big one. So if you make an incision here, you're not going to see anything. Don't be a hero, really. To make an incision here, so I'm going to do it right. No, you just put a big pen there in this area, and just leave it open until 911 comes. That's all what you needed from you. When the partial goes there in the trachea or the implant. So just want to make sure. The last part is adhesiveness. That's one of the reasons the failure of the implant. You know, most common post-operative complication is just open. You've done the job, everything is wonderful, the implant is great, retention, osteointegration, and so on, and then the patient comes back, we have open adhesive.
Dehiscus in Latin means opening. Okay, so it's open. It happens in medicine a lot. The abdominal surgery, they come back, it's been back again, it's open, and the guts are coming out. The same thing. Yeah, that is true. Very common. Very common in surgery, abdominal surgery. So you get dehiscedness in the implant. What is the contributing factor? We know that in periodontitis, we all know that about tension. Don't tighten that. So you give it the chance to rest. You know, when you do your suturing, just don't put too much tension on it. Okay? Too much trauma to the tissue itself, irritation, incorrect incision, poor quality mucosa, very thin type, like for example in the anterior, very thin type, you have to be careful about that. Or you have a patient really bad, you know, maybe smoker, diabetes, irradiated patient, all these, you might expect to see some dehiscence. The treatment, if it's a small, don't do anything. But if it's a large, we really have to redo it. You know, you cut it back again and start doing it. And you might have to refresh the tissue itself. Sometimes if the epithelium just came back, it's not going to heal. You really might have to just take out the surface layer of the epithelium so that the epithelium can crawl back and heal. Otherwise, it stays open for a long time and you want it to heal. For connective tissue graft, allow better aesthetical results, maintenance of the implant, of course. You know, if you have all these problems, get rid of them, then you can solve this problem of dehiscence. And maybe you can prevent it, pre-operative assessment of the soft tissue. Look at keratinization, look at planning for your technique, minimally invasive flap elevation as much as you can, that's a standard. Proper suturing, no tension. Temporization, if you're going to have a rebasing or relining, yeah, cover it. Delaying the use of removable denture. Finally, mandibular fracture. There are fractures happen for implants, definitely. Okay, and fracture of mandible in connection with placement of the implant is relatively rare. That's the good news about it. So, but if you have a case like this, very atrophic thin mandible, and you're going to put an implant, you might have a fracture in it, you know, or vulnerability of that thermal injury, heat, tremendous amount of heat. It's not going to fracture immediately. But when the necrosis happens, it will fracture, okay? And for whatever reason, the strength of the mandible is very thin, so it will fall down. Here's a good example, is people will do implants, and that not knowingly they go on the lingual side, and the mandible is very thin, you can easily have a fracture, you know, perforation of the lingual cortex during drilling. Okay. So central mandible is always a problem. To treat that, stabilization. Now I know if that happens, some of you'll have problems in the maxillofacial mini implants, the mini plates they always use, or you split implant. And if you want to be careful, look for a thin mandible for the X-ray. Okay. If you want, as I told you, you can put bone graft. Or let somebody do the bone graft and use CBCT to get good results. The final part, emphysema. Might not happen to you, but it happens in implants. Rare complication, can lead to severe consequence, inadvertent sublation, propulsion into the tissue, especially those who use high speed. Not for the implants even, you're using for something else, you know. As Dr. Shorkat, maybe you say, oh, I gotta take that excess resin from this area, you use a high speed, might not know, and you can inject that inside the tissue itself. Okay, air water syringe, air polishing unit, okay, or reject, for example, or laceration. The best example is compression. I definitely was doing a maxilla removal of the third molar, the maxilla, and in front of me. I mean, I don't see emphysema, but just as I took the tooth, the guy's ear puffed like this. Oh my goodness. Luckily for us in the clinic, we had something from Shoppers Drug Mart. It's a cold pack. Break it down, it becomes like ice, and just packed it. For half an hour, I stayed on him. It's not half an hour on this. It went down. It really went. It reacts to treatment. Here's a good example of an emphysema. Here, tissue emphysema. It can happen very easily. Thank you. There you go.
Awesome.
Really questions? I'll be glad to answer you. Yes, sir.
With regards to the anesthetic they use, I know some say for a block and use artery.
Yeah, controversy about the anesthesia. I mean, I really don't. We use Articaine or have no problem at all. We use
College.
Royal College.
Yeah. What do they?
But I didn't. Did anybody? I didn't hear anything. The Royal College, but I could be wrong. I don't use. I use art. I use actually whatever we have in the clinic. Go ahead. To be honest with you, I didn't have any trouble with this at all. Did you heal something from the
No,
college?
no, I haven't. But I know that Dr. Haas
Yeah.
strongly.
Again, yeah, he published the paper on that Articaine. Oh yes, I know him. He's the dean of Toronto. Yeah, I know. But I don't, we really don't. Maybe that's the difference between Western and Toronto. No, I can't answer that. I can't answer that. Unless somebody knows the answer. Any other question, I'll be glad to.
Thanks, Dr. Galil.
Yeah,